Okay, so why are the first few seconds of an encounter so important? Come on, all you guys who step back. Why do you think?
Sets the tone for the rest of the encounter very quickly.
Sets the tone, exactly. Why else?
I think the first impression is maintained, like that opinion is
Mhm.
maintained.
Whose first impression?
I guess both ways, but here we're talking mostly about our communication with patients, so the patient's impression of us is set pretty quickly, and it's hard to walk back from that if it's not a good impression.
Exactly. And then the other thing is, it also, as you said, it sets the tone and first impressions. If you have a patient sitting there with their arms crossed, looking really unhappy, you're not going to come in all like, hey, hi, I'm so-and-so. You know, you'll change your tone maybe to meet theirs. Maybe you won't be miserable and unhappy, but to meet their, what you've already perceived. So those first few seconds are really important both ways. And so we're going to do the first skill set is skill set 1. We're going to talk about this for probably about 10 or 15 minutes, but actually the whole skill set should take no more than 90 seconds, okay? Just so you know. So it'll seem like a long time, but really 90 seconds at most. Because remember, we only have a 20-minute visit or a 15-minute visit or something like that, depending on the department. So in terms of creating rapport quickly, what we recommend is that first you stand outside that door, take a deep breath, get rid of all of the other crap that just happened, and then knock on the door so that you can be fully present for the next person you're going to meet. And then we suggest a welcoming statement like, I'm glad to meet you. So we don't recommend using how are you. Might any of you know why? Or take a guess why?
They're usually not great.
Usually not great, right? So you may get some snarky comment like, I wouldn't be here if I were fine, right? Or the other thing that sometimes happens when I say, how are you, is they immediately go into their spiel. Like, oh, this, when really I was just trying to make polite conversation. So that's why maybe not the how are you. And then always introduce yourself, and especially now with the PPE, I say something about it immediately, really early on, like, sorry that this is such a mess, blah, blah, blah. But so always introduce yourself, tell them your role, because patients oftentimes see a lot of people and they don't know who you are, even with the big badgy thing on our chests. And if you're late, you can apologize for it, or you can say you appreciate their time, or their time is valuable, just so that you acknowledge that you inconvenienced them. Attend to comfort and distraction, so if it's really cold in the room, maybe offer to get a blanket or a cup of water or whatever that might be for this particular patient. And then sitting down is best. So in the outpatient setting, sitting down really isn't a problem. There's always a chair in that exam room. Inpatient, it presents a lot of problems, at least for me. So is there anything any of you do inpatient side that you're able to sit down and actually talk with a patient? Many of you actually don't have inpatient kind of roles here. I understand that.
I sit at the edge of the bed sometimes.
You'll sit at the edge of the bed?
I ask them permission if I would sit on the bed with them.
Yeah. Do you do that in COVID?
Not as much.
Yeah. Any other thoughts?
Theoretically, if they've had surgery though, they've been tested. So.
That's right.
Right. Although you haven't.
That's true.
Yeah, so I was actually thinking more for the patient, but that was, yeah. Yeah. So there aren't any good options. Sometimes there's a chair available, sometimes the windowsill works. The common thing is to actually just try and bring yourself down to their level. And so even if you can't sit, if you can be sort of at the, closer to the bed and do sort of a wide stand or a squat or something, just so you're not peering over them, is thought to be better. The other thing with sitting is patients immediately think you've spent a lot more time with them if you sit down than when you're standing. And one of our other facilitators tells a story about her mom arranging this chair to talk to her oncologist. She comes into the room, the facilitator, her daughter, wants to sit in the chair, and mom's like, no, that's for the doctor, you go sit over there. The doctor comes in and declines the seat and spends about 45 minutes answering all of her questions, having the same conversation, and the mom was completely dissatisfied. He didn't spend enough time. So it really does make a big difference. And then we want you to do small talk before big talk. And so for a new patient, it may just be, how is it coming in, or, masks or, really interfere with our ability to converse, or if you know the patient, how's your dog, grandmother, grandfather, son, daughter, whatever the case might be. Just something to make them feel a little more comfortable, and it can be quick, something about the weather, something about the commute. And then the next thing would be minimizing communication barriers. I do that early on, and just immediately mention the PPE, because I'm there, and as all of you are, in masks and shields, and all they can see are your eyes, and sometimes they can't hear you well. When I first saw this picture, is it okay if I do this to you?
Yes.
Anyway, when I first saw this picture, I thought this was the craziest picture to have communication barriers, because this is someone going to sleep in the OR. How much communicating are you really doing there? And then Terry told her story, and then I felt bad.
So my husband has a genetic abnormality in his family where I think many of them have a hearing loss, and my husband and both of my kids have it. So my son is 20, and he's been in the operating room multiple times for orthopedic injuries. And it never occurred to me until this moment that he probably was scared to death because he couldn't hear what she was saying as she's putting him to sleep, because he relies on lip reading. I mean, he can hear, he's got hearing aids, but they would take them out when you go to the OR, and he can't read because of the mask. And so this actually touched me quite a bit. I love this picture.
Yeah. And so in the clinic, what do you guys do for patients, elderly patients who come in who are really hard of hearing? Any thoughts or suggestions on that? You just scream?
And just make sure, maybe ask them to repeat something that you said so that you know that they're hearing you. Something like that.
That's
Or
great.
before, we have people that read lips, or we'll ask, do you want me to take my mask off, and we'll keep the shield on and just sit back? Because they'll tell you usually if they'd like to see your mouth when you're talking.
Yeah. Anyone else? So my favorite trick, which I used the other day and it worked really well again, I'm always shocked by how well it works, is I get one of the nurse's stethoscopes because the tube's longer. And I put the stethoscope in the patient's ears and I talk into the bell. And that works really shockingly well. Even with their hearing aids in, I just shove it all in there. Yep. And so, yeah.
Can I tell the language one?
Yes.
So,
Yes.
Or you?
No, go for it.
So one of our facilitators, when we were training, she said that there's a group in Minnesota where their practice is when they have someone who's non-English speaking, that they actually say to the patient, I wish I had was able to speak your language. So it makes that connection. I want to be like you and I want to be able to communicate, but unfortunately we're going to have to go through the interpreter.
Yeah, thank you. So then the other barrier to communication for us now is the EMR. It's not as bad as it was when it first came in and patients were really not used to having a computer in the room, but it's always nice to signpost when you're going to use the computer. So does everyone know what signpost means? Maybe not.
I didn't, so if you don't feel bad.
Okay, so signposting is
Maybe.
actually just seeing something completely obvious. Like, in order to get a really a thorough history, in order for me to make sure that your history in the chart reflects exactly what you're saying, I want to do some typing right now. Or I'm going to turn the computer on right now because I want to show you pictures. So they don't think that you're being rude by just turning your back and just doing stuff on the computer. And just signposting it, like I use my phone all the time when I see patients to use a calculator because I do nutrition. So I'm constantly figuring out all sorts of crappy, you know, changing their weights into pounds versus kilos and then figuring out protein and blah, blah, blah. And every time I go to use my phone, I tell them exactly where I'm going and what I'm doing so they don't think I'm answering a page or texting my buddy or whatever the case might be. So that's signposting. And so it's the same thing. When you come into the room, please don't sign into the computer before actually saying hello. That would be considered rude by most. So you come in, you introduce yourself, and then you know how long the computer takes to boot up, sometimes forever. And so you may say, like, you know, hi, I'm so-and-so, blah, 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 I'm so happy to meet you. The computer is here in the room with us, and I'm going to try and put some important information in there for you. I needed to get started booting up because it takes a long time. I'm just going to do this, and you do your swipe, and then go back to the patient, just so that they know what's going on and they understand that you understand that what you're doing might be a little bit rude, but it's going to be okay. What other time would you not want to be on a computer besides when you're introducing yourself? When you have a patient interaction. So, anyone?
When they're telling their story, you probably want to be engaged with the patient and not looking at the computer.
So unless you're a stenographer, you know, and you can be like this and everything is great, I agree. But even more so than that, it's when they express emotion. So if a patient is very sad, if they're tearful, please stop typing and turn around and fully attend to them. Maybe lean forward, be supportive. Sometimes a touch, we'll talk about that later. COVID era, touching isn't that great. Okay? Yeah, okay.
So how many of you have had this experience? You feel like you're all done, you got your hand on the doorknob, and the patient says, oh, by the way, doc, what about, you ever have that happen? Me too. And so the goal of this skill set really is to prevent that from happening. And it's really about getting everything out on the table to start. So we're going to start by asking the patient to elicit all their concerns so that you have a list from the start. So you're going to create that rapport, and then you're going to say to the patient something like, you know, in order for me to make sure that all of your concerns and questions and symptoms are addressed today, I'd like to just start by getting a list of what you wanted to talk about today. How many of you have fear in your heart right now? Yeah, right? So why would we do it? How many things do you think the average patient brings when they come in? Concerns, questions, etc. Hmm. 10. That's what my head tells me too.